When should you do a neonatal screening for a condition? When it is common, when there is a screening test which is available, when there is a lag time which is there, and when there is an effective intervention. So let's go one by one. So is 21 hydroxylase common? How common is 21 hydroxylase deficiency? 10 to 15,000. Okay. So it is relatively common. Is it life-threatening? So the salt wasting form can be life-threatening. Do you have a good test? 17-OHP is a good test. Do you have a lag phase? So you have 2 weeks, 2 to 3 weeks before you. So why are you doing a screening? You're not doing screening to pick up PCOS may happen later. You're not doing it for precocious puberty. You're doing for salt wasting. So you don't want the child to die. Particularly, you don't want the male child to die who will have no other manifestations. So the main reason is that you want to pick it up at day 3 rather than 3 week, 4 week when the crisis has happened. So you have got a lag time. It is a relatively common indication. You've got a good test and you've got a good treatment. So everything fits into this screening concept. So you should go ahead for screening for this condition. So the rationale is it is around 1 in 10 to 15,000, high risk of mortality for the salt wasting form. Now what we do is that you can look at 17-OHP level at day 3 of life. Why day 3 we discussed? Because of the CRH surge. You can use a filter paper. But remember, this is a screening test. Now this is a big error. Often I get referrals from people who have a clinical case of CAH. Suppose somebody presents you with DSD. He is not screening. He is already a clinical case. His pre-test probability is very high. So there you should not go for a screening test. There you should go for a proper test because this test will have a lot of fallacies. Screening test is not a perfect test. It is not meant to diagnose the condition. So use a diagnostic test if you have high pre-test suspicion. This is for every child who is born, then you go for this test. Now, after that, there are protocols and many US indications are that if your level is above a particular level, because of a high false positive rate, you should go for a GCMS, which extracts and does a GCMS giving a better picture. And only if that is high, then you recall the child. Otherwise, the recall rate will be very, very high in that scenario. The problem is that you will have false positivity. I discussed stress, prematurity, early sample, something like thyroid. What is the difference in the impact of prematurity in hypothyroidism screening and CAH screening?
The hypothyroidism screening,
will you pick up or will you miss?
We will like to miss because of the central hypothyroidism picture, and
there is a delayed surge. So you will miss. Here it's an early surge. So what you need to simply remember is that 21 hydroxylase is opposite as far as congenital hypothyroidism screening. In prematurity, you are more likely to have a false positive CH, false negative for thyroid. That is why thyroid you repeat it after 2 weeks, 3 weeks. Here you have to repeat whether it is a falsely positive. That is a different thing. You have not missed it. Here you don't want to unnecessarily diagnose it. So it's just the opposite in that regards. If mother has received steroid treatment, you will have falsely negative. Which steroid? So if your mother is on SLE, on hydrocortisone or prednisolone, what will happen to 17-OHP in the baby?
Then it can travel to the placenta and it can suppress. It can suppress, but the suppression activity is not that high.
Does it cross or does it not cross?
It cross.
Which?
17 hydroxylase can cross.
Hyzone can cross. So mother who has adrenal insufficiency, it will cross and it will cause a problem in the baby. It does not cross. That is why when you treat, you use antenatal dexamethasone. For treatment for lung maturation, you use dexamethasone. For the experimental treatment of the newborns to prevent virilization, you also use dexamethasone. Now, my question now is, why does it not cause? So, placenta basically is a sieve. We have discussed this when we talk, and we'll discuss again when we talk about physiology. We'll talk about that placenta is not just a carrier. It's not just allowing everything to cross. It has got specific enzymes to inactivate. It has got as discussed, monodeiodinase, which is going to allow thyroid, only some part of thyroid will cross. It has got 17 beta HSD, which is going to inactivate testosterone, which is going to inactivate estrogen. It has got 11 beta HSD, which is also not going to allow cortisol to pass. So hydrocortisone and prednisolone will not cross. Dexamethasone can cross. So if some mother has been given dexamethasone for prematurity, or suppose for HMD prevention or whatever, in that case, your 17-OHP may come down in that scenario. Now, what you need to remember is that the positive predictive value of a screening is 1%. Now, what does that mean, Vibha?
Finding that true positive is very less.
No. What is what is positive predictive value mean of 1%?
Getting the
So if you have 100 patients with CAH, how many are you picking? 99 you're missing. Then why are you having a screening test? What does this one positive predictive value means?
It means the screening test, what we have done,
Mm-hmm.
among them, how much we are getting truly positive. This is
So if you have 100 patients whom your screening 17-OHP is high, one will have the disease. It will not miss. That is that you have to look for sensitivity. Sensitivity is how many you are picking up. Or you can say negative predictive value. If it's negative, how many are there still positive or not? It means that if you just use extraction without extraction 17-OHP using an immune assay, only 1% positive predictive value will be there. So it's not a very, very good. And then you will have to call 99 children unnecessary. What is the false positive rate? So you have a high false positive rate, if you talk in that sense. What is the false positive rate for TSH-based assays?
false positive rate for
For congenital hypothyroidism? No, it's like 3 times, 2 to 3 times. So out of 3, 1 will have this. Out of 100, 1 will have this. So this is, you have to be careful. So how do you do that? So if you want to improve the positive predictive value, what can be done?
the pretest probabilities and then
No, screening may how the pretest probability will be high. It will always be 1 in 10,000. That is why the positive predictive rate is low, because your pretest probability is so low, 1 in 10,000. Suppose somebody had a DSD, then your pretest probability is 60-70%. DSD with palpable gonads, you are saying 90%, this is 21 hydroxylase, and your screening is positive, you will be happy. But if you have a normal child and you have a positive 17 OHP, then the question comes. Then it is 1%. So what all can be done to improve the positive predictive value of a test? You can't improve the test beyond a level. What will happen if you increase the cutoff?
yes.
So you said that 17 OHP of 3, I am considering positive. Let's assume, let's make it 10. Then this positive predictive value will go up. But your sensitivity may come down. That is one. Second, you add a second tier test, which will then, so this is your first screening. This is like you have got a IIT exam, you have got the first prelims, and then you have mains and all those things. So you have got the first screening. The second screening, you have a more strict test. That will filter out the unnecessary noise. So it is more like getting the actual people who need evaluation rather than those 99, because everybody will become problematic in that regard. So you need to use, first of all, gestation and weight specific cutoff. This is a big problem. Now people use different cutoffs, and I said that it is not same for everybody. Somebody is preterm, you will have a higher level, low birth weight, stress, all those things you have to look at. And you should do a GCMS based assay to provide a better strategy. So if you just use a EIA, immunoassay, you will have 99 unnecessary called. But if you use specific cutoffs, if you do the second assay, your positive predictive value will improve. And this is important because often you will get referral for somebody who's 17 OHP is 6, 7, 8, and they said it's positive in screening. Most of them will not be CAH, 21 hydroxylase. This is the message I want to give from this perspective. So what do you do in 17 OHP level in neonatal screening? Less than 300, less than 3, fine. It can't be 21 hydroxylase, forget about it. More than 12, it's likely, but still it is not final. As I said, a lot of false positive, that is why your positive predictive value is less. you do a 17-OHP ideally by a tandem mass spectroscopy. Or if you can't get it done, then maybe you should do a new 17-OHP in the blood at least. And by the time these results are coming, electrolyte, something might start coming up. Examine the child carefully for pigmentation, for DSD, some milder forms you can think of. 17-OHP, and if in doubt, you can think of a genetic testing which can be considered in this scenario. If the levels are between 3 and 12, 300 and 1200 nanogram per DL, again, you have to not think of 21, but yes, sometimes you may get other rarer forms, 11, 3 beta, POR. So look at the clinical picture. Message is less than 12, 21 hydroxylase is unlikely. Because the sensitivity is high, it is not going to miss 21 hydroxylase. The only problem is many normal people will also have a level about 12. So then you add a second level. So that is why that when you have 10 lakh people giving IIT, you can't take everybody for the main exam. You have to first screen out. Okay, now I will take only 1 lakh. And then you go for the next test. So this is how the double level screening will help out. So if you are in front of a big sunlight, you have got, or let's say when you are in an operation theater, you use double mask, double gloves. That is all because of that you have extra protection. So the same thing is happening in that perspective in neonatal screening. So day 1 neonate on screening 17-OHP is 1400. And we talked about 12 and above is high. What would you do here, Vibha?
You should get it confirmed correctly on this.
PMS. Okay.
Day one, we can't consider.
So this should not have been done. So this is a falsely an advised hydrocord. So of course you've got one step ahead. This is basically at the wrong time. So too early given in that scenario. Now, special scenario, if you have suppose features of this thing and still the 17-OHP is not high. So it may happen that there was a problem in the blood collection, the problem in the test or whatever. So it may be rarely false negative. So repeat at 10 to 14 days. Why 10 to 14 days? Because till then the confusion will be all over. Many of the sulfated steroids will be less. Many other features will become much easier. So 2 weeks will be the best time to repeat in that scenario. Now, antenatal steroids, this is an important message. So if mother, so always ask this a history. Whether the mother receives, so I'm talking now about false negative. One false negative is a pre-analytical issue or an analytical issue or somebody is reported wrongly, anything can happen. Second is mother got steroids. So in that scenario, you wait for 14 days and repeat it. After that, by that time, your effect will go. Because the half-life of dexamethasone would pretty much be like 1 to 2 days and it will wash off by maximum 8 days. So 14 days is very safe in that scenario. Then if somebody is stressed out, like illness, like admitted in the ICU, in that setting, you can have multiple parameters. You have to be careful and you repeat at 2 weeks.